Good morning to our West Coasters, and welcome to our Alpha Phi sisters, friends, and the Duke University School of Nursing community. My name is Mary Beth Tully, and as Alpha Phi Foundation Board Chair, I'd like to start today's event by saying how thrilled we are to partner with the 2021 Heart Health Grant Recipient, the Duke University School of Nursing. Alpha Phi Foundation looks forward to working together to improve heart health outcomes for women everywhere in the months ahead. Now, Alpha Phis are very familiar with how pervasive and often lethal heart health issues can be, especially for women. And despite a growing awareness over the past several years, according to the CDC, only about half of women recognize that heart disease is their #1 killer, proving that the need to better understand and create tailored treatments and effective prevention methods has only grown since Alpha Phi chose heart health as its philanthropic focus in 1946. Now, in 1993, Alpha Phi Foundation established the Heart to Heart Grant to provide annual funding for vital research and education that improves heart health outcomes for women. And since that time, we have invested over $1.3 million to fund cutting-edge research and educational projects. Alpha Phi Foundation's unwavering support in the area of women's heart health is made possible only through the generosity of our donors. Thank you for believing in our mission of advancing women's lives through the power of philanthropy and for leading with your heart year after year. I'd also like to take a moment to recognize 56 exceptional Alpha Phi alumnae with expertise in the medical and research fields who volunteered as medical readers this year, giving their time and talents to evaluate heart-to-heart grant applications. Thank you, sisters, for helping to make this grant possible. Today, we are so proud to introduce to you the Duke University School of Nursing and their research project, Improving the Visibility of Women, Patients as Partners in the Management of Uncontrolled Hypertension. Led by Dr. Brady Granger and Dr. Holly Biola, in conjunction with Awana Caesar at the Lincoln Community Health Center, this project will use a community-based intervention that will identify and reduce disparities and inequities among women with high blood pressure, resulting in a decrease in the proportion of women with hypertension. Now, in a few moments, we'll hear from the Dean of the School of Nursing, as well as the project investigators, Dr. Granger and Dr. Biola. And then we'll have the opportunity for some Q&A. So if you have a question, please use the chat function in Zoom to submit your questions to the real Alex Goodman at any point throughout the event, and we'll try to answer as many questions as possible. Now, it's my pleasure to introduce the Dean of Duke University School of Nursing, Dr. Vincent Guillermo Ramos. Dean Ramos came to Duke on July 1st from NYU, where he was professor and associate vice provost for mentoring and outreach programs, and held academic appointments in the NYU Schools of Nursing, Social Work, and Public Health. He is the 12th Dean of the School of Nursing, the 2nd Alumni Dean, the 1st Male Nursing Dean, and 1st Latino Dean at Duke. Dean Ramos is a nurse practitioner, dually licensed in primary care and psychiatric mental health nursing, and he is credentialed as an HIV specialist by the American Academy of HIV Medicine. He maintains an active research program garnering extensive funding from NIH, CDC, and other federal agencies and private foundations. And he is well known as a leader in reducing health disparities among youth in Latino and other ethnic minority communities, and is the founder of the Center for Latino Adolescent and Family Health, which develops, evaluates, and disseminates family-based interventions and nurse-driven models of healthcare delivery that are designed to reduce health inequities and promote overall well-being among Latino youth and their families. Please join me in welcoming Dean Ramos.
Thank you so much, Mary Beth. And before I start, I just want to take a moment to thank everyone for being on today. and for the support from the Alpha Phi Foundation. I appreciate the opportunity to participate in this event as we recognize the new partnership between the Duke University School of Nursing and Alpha Phi Foundation in advancing women's health, particularly heart health research and education, by supporting groundbreaking research that directly impacts care, health outcomes, and patient empowerment. The Alpha Phi Foundation is transforming the health and lives of women across the country. It is an honor for the School of Nursing to have been chosen as the recipient of the 2021 Heart to Heart Grant. Before I introduce the co-project investigators, Dr. Brady Granger and Dr. Holly Viola, I want to share a little more about why this support is particularly meaningful for the School of Nursing. Currently, there's a spotlight on the indispensable role nurses play in the overall health and well-being of society. Not just the role that nurses play directly within the healthcare setting or at the bedside, but how nurses impact health equity and the drivers of health disparities. We know that an estimated 1 in 4 women in the US will die from some form of heart disease. This is a staggering statistic, especially when we consider that many women are not aware that heart disease is as great of a concern for them as it is for men, and that it is a disease that is mostly preventable. We also know that hypertension disproportionately affects women of color, women from lower socioeconomic backgrounds, and that women may not have easy access to healthcare. One of my key priorities as dean is to ensure our School of Nursing is well positioned to make significant strides in the reduction of health inequities, and so that all individuals, families, and communities have the potential to live their lives to their fullest health potential. With nurses representing the largest segment of the healthcare workforce, nurses are exceptionally positioned to have a significant impact in responding to health disparities and addressing the social determinants of health. We have nurse scientists working on projects that are developing evidence-based personalized interventions in community settings that will increase pre-exposure prophylaxis, awareness to reduce HIV infection in women. Creating a mobile app that allows underserved families living in communities to self-support their needs, receive information about critical illness, and improve their understanding of unmet palliative care needs. Implementing grassroots strategies aimed to reduce acculturation stress, increase resilience, and improve access to health and social services among Latino immigrant families, and evaluating a family-based nurse-led community COVID prevention intervention designed to increase testing, vaccine uptake, behavioral mitigation, and reduce psychological distress among households in economically disadvantaged communities. I believe that it is incumbent upon schools of nursing to become engines of change, and our nurse scientists are doing just that. A nurse scientist understands the drivers of health inequities while also being able to identify the factors that are most amenable to change. Nurses are trained to think critically and are highly skilled at identifying approaches that have impact. This project is a prime example. Brady and Holly and the full team are not only looking at how to reduce hypertension and empower women to advocate for their health, but are also addressing various barriers these women are experiencing by utilizing community-based interventions to overcome some of the key social determinants of health. It is now my privilege to introduce Brady Granger and Holly Viola, who will share with you more about their project, Improving the Visibility of Women, Patients as Partners in Management of Uncontrolled Hypertension. This project relies on community-based intervention to identify and reduce disparities and inequities among women with high blood pressure, which will result in an increase in the proportion of women with hypertension under control. Brady is a research professor at the Duke University School of Nursing, director of the Duke Heart Center Nursing Research Program, and adjunct faculty member at the University of Gothenburg, Sweden. She is also a core faculty at the Duke Margolis Center for Health Policy. Brady is an active member of the Council for the Advancement of Nursing Science, the American Association of Critical Care Nurses, the American Heart Association, and the European Society for Patient Adherence, Compliance, and Persistence. She is also an alumna of our Masters of Science of Nursing program. Holly is the Chief of Family Medicine at Lincoln Community Health Center. Holly sees patients at Lincoln's main location in Durham, specializing in family medicine and preventative medicine. She is a recent president of the Duke Orange County Medical Society and the current president of the North Carolina Academy of Preventative Medicine, and has been working with Dr. Granger for the past several years on severe hypertension outreach projects, focusing on Durham residents at highest risk of cardiovascular events. How these products have been funded by the American College of Preventive Medicine, the CDC's Division for Heart Disease and Stroke Prevention, the American Heart Association, and Lincoln Community Health Center Foundation. Brady, Holly, I now turn the program over to you. Thank you.
Thank you so much for the introduction. I will share my screen and Dr. Biola will get us started with the presentation. Thanks again to all of you for allowing us this opportunity to be here today.
I just want to say another heartfelt thank you on behalf of Lincoln patients and providers for your generous support of this work. We're trying to empower patients to manage their own blood pressure in their real life outside of the medical setting. And I just wanted to say, lay the groundwork a little bit about who we are, where we are, what we're doing, or what we've done to lead us to this point. If we can get the next slide, please.
Yes. I'm finding my controls.
Okay, so Lincoln Hospital was constructed in 1901 to care for Durham's African-American citizens. In the 1960s and 70s, as care became integrated, Lincoln was restructured in the same neighborhood as an outpatient facility. Now, Lincoln Community Health Center provides outpatient primary care to about 36,000 adults and children, as well as dental, social, mental health, nutrition, and many other services out of our 10 different locations around Durham County. Next slide. I could start talking about the next slide.
I apologize.
No worries. So as you may know, hypertension, and this was discussed, or high blood pressure is more common in patients who self-identify as Black or African American. These numbers on this slide come from the National Health and Nutrition Examination Survey, which is conducted annually via a combination of interviews and physicals with thousands of Americans by a branch of the CDC. You can see the large disparity here between the overall prevalence of blood pressure, high blood pressure, or hypertension in everyone else versus just patients who identify as Black. Next slide. So the reason this is important is that hypertension, as Dr. Ramos said, is a modifiable risk factor for stroke, heart attack, kidney failure, and death. This slide shows the disparity in deaths per 100,000 due to hypertensive diseases. And you can see the top two lines are the African American or Black community. The lower line is white men. I looked everywhere for a line for white women, and it's down there somewhere south of the white men, but they don't have one. Next slide. So nationally, you can see the prevalence of hypertension is higher in the Southeast, some call it the stroke belt. And Durham, North Carolina is right here in the middle of the stroke belt with a very high prevalence of hypertension. So in the middle of the stroke belt, in the middle of North Carolina, in the middle of Durham, to the east side sits Lincoln Community Health Center. As I said, we're serving adults and children as well, but the 25,000 adults that we serve, about 39% of them, the year that we started really working together, had a hypertension diagnosis. And this was our controlled, we consider controlled high blood pressure to be under 140 on the top or systolic number and under 90 on the bottom or diastolic number. So about 3,000 patients with what we would consider uncontrolled hypertension. Next slide. So as a federally qualified health center, Lincoln is required to report certain quality indicators to the federal government every year. When we see problems or trends, our quality improvement team tries to take corrective action. So when one might look at our little increases in control over the last couple of years and say, oh, look, they're making improvements. Just remembering that we have 9,000 or so patients with hypertension, it takes a lot of effort to make any budge in these numbers. So while one might think we're doing better, if you look at the disparity between our patients who identify as Black and the rest, our overall numbers, the disparity was actually increasing. This is not a Lincoln problem, I want to say. This is a Lincoln problem, but it's not just a Lincoln problem, and it's not just a North Carolina problem. This is a national problem, which is why those hypertension-related death data are so disparate. Next slide. So when we first started looking at this, we took our 2016 reports that we sent to the federal government and just sorted top down, what's the worst blood pressure we've had here this year, and just about had a heart attack ourselves when we saw that there were almost 100 people with just really frightening blood pressures. So you can't unsee that. So after we saw that the blood pressures lined up with the names, we said, oh, we have to do something. We have to do it right now. So we showed this around the building and made partnerships across departments here inside Lincoln Community Health Center with patient navigator, a pharmacist, social worker, to try to help get our heads around the problem and what could we do to help these folks with the highest blood pressures. And we found lots of social determinants at play: lack of transportation, lack of copay for return visit. Our pharmacists were able to tell us whether our patients were actually filling the medications we were prescribing, and we were able to construct a hypertension treatment algorithm to help our providers choose the best first or best next blood pressure medicine for their patients, depending on the most available evidence. Next slide. So what we found was that if we could get patients to engage with us, we could help them get their blood pressure down. This graph shows the average systolic, or the upper number of the blood pressure at the start of our work in 2017 and at the end. Next slide. Following year, the American College of Preventive Medicine and CDC we applied for and received a grant to work for 3 years on improving the disparity control and blood pressure control, specifically between Black men and all other patients at Lincoln. They required that we focus our efforts on self-monitoring of blood pressure at home, which is an evidence-based intervention. So giving out blood pressure cuffs was part of this work. And we developed a curriculum for basic blood pressure education and self-monitoring at a 5th grade level or below. We worked from a list of patients with very high blood pressures to make sure they got cuffs. We wanted to make sure we were reaching out to folks at the highest risk of heart attack and stroke. So we invited patients to in-person classes. And then when COVID hit, we pivoted to telephonic education using student volunteers whom we trained. We collaborated with our in-house, I'm still back on that. I'm going to be on this one for a while. Sorry. So we collaborated with our in-house social workers and pharmacists to help find the medication assistance programs that people might be eligible for. And in year one, we were able to get 267 blood pressure cuffs out to patients with hypertension. And we were happy to see that the patients who identify as Black males at Lincoln were appropriately overrepresented in the patients who got a cuff. So 25% of our patients with hypertension are Black men, and 34% of the people who got cuffs were Black men. And that was intentional. We strive at Lincoln to provide care that is equitable. I like this image at the bottom demonstrating the difference between equality and equity. We want everyone to see the ball game here over the fence. So we provide different amounts of assistance to everyone according to their need. It's clear that our Black patients are suffering more from the burden of hypertension, so we feel that targeting our interventions towards them is appropriate. What has not felt particularly appropriate is targeting all our efforts just towards Black men when we have even more numbers-wise Black women with severe hypertension seen at Lincoln Community Health Centers. Enter Alpha Phi Foundation's funding, which allows us to expand our outreach efforts to Black women as well. Next slide. So this is the most recent, and the 2021 numbers have not yet been finalized. These are sent off to the federal government in February, but these are what the numbers look like right now. And we're really excited to see that after really working hard on this issue, we are finally starting to see some improvement in hypertension under control numbers for our Black patients here at Lincoln, and also an improvement in the disparities. And we cannot wait to see what happens when we are working with women as well. And I'm turning it over to Brady.
Thanks, Dr. Biola, for setting the stage and really, I think, describing in great detail the disparities in our local area and also the disparities nationally. We will now, thanks to the partnership with Alpha Phi, begin a hypertensive outreach project with women. The overall purpose of the project, which has been stated, is again to improve the rate of blood pressure control in Black women, one of the highest killers of women in this group. The intervention itself, I will describe a little bit more about that and how we will engage the Alpha Phi chapter members here at Duke. But we will focus, as Dr. Biola has described in previous work that we've done, we will focus on the most severe, most uncontrolled women first. And in this particular project, we will use an innovative approach to one-on-one intervene with women in this very high-risk group. We will partner and have, as you'll see later on this morning, with Alpha Phi student ambassadors to help engage these high-risk women. We will provide tools, including blood pressure cuffs, but also real skills and knowledge to be able to self-monitor blood pressure more independently. And then the most innovative aspect of this project will be the menu of options. So we are really trying to help tailor blood pressure self-monitoring strategies to the everyday life of the women who need it most. So here's the first step in the process is simply to make contact with these women, and making contact with busy women is challenging. And I think all of us can appreciate that and have experienced that, the fact that often our healthcare does not come first. It's the healthcare of our kids or family members or other people that comes first for women. So our very first step in this study will be to make contact. And these are some examples of scenarios of what this looks like. And we begin with a phone call and an introduction in an effort to establish relationship. So the caller will say, hi, I'm working on a high blood pressure project with Lincoln Community Health Center, and we are here to help you and ask, do you have a blood pressure cuff at home? And then a couple follow-up questions of what works best for you in terms of getting a cuff. So in this first step, we attempt to make contact, establish relationship, and assure that women have a blood pressure cuff that works for them, that is convenient, accessible, and not requiring a lot of extra work on their part. Next, step 2, we have an activities menu, and this menu is an evidence-based menu from the American Heart Association and the Centers for Disease Control that we have a lot of evidence about what works to help control blood pressure, but it is challenging to work these activities into the usual everyday life of women. And so the second step of our study will be to lay out activities that are effective and evidence-based and help women choose activities and tailor those activities to their everyday life. The last and maybe most important step is shown here on the slide, communication. And this is where our Alpha Phi participants come in. We are really excited to work with them to communicate with women and be able to give more feedback and more interaction with the women who need it most. And then step 3 is the community connection. So after we've made contact and ensured that women have a cuff, then the next step will be to really develop a relationship. And here we seek to empower patients to select a community partner, engage with their primary care provider. The intervention and our Alpha Phi partners will address barriers to care, and these barriers we know range from simple things like transportation to very complex things like finances and childcare. So those are the kinds of things that we will work through with each individual woman in terms of helping them tailor a plan that works for them. These are some of the tools and activities we'll share with the women, and I'll just say that these tools that I'll briefly show are all evidence-based tools that have been available for a long time, but again, not in the hands of the women who need them most. And so we will work together with the students and the patients to make sure that patients know what elevated blood pressure is, that they know the correct way to take it. And this is reviewed using a skill-based teach-back approach to help patients understand that taking the blood pressure correctly is actually important, and that they're reading and following these 7 steps on the right-hand side of the slide may indicate that their blood pressure is better than originally thought or not. But regardless of what that accurate measurement is, we provide feedback and tools to help women interpret what to do next. And so we have a training program that our Alpha Phi student ambassadors have attended and passed with flying colors. And as a result of the program, they are, I feel, confident and able to coach patients in what to do with the reading. And this chart here is given not only to the patients and the students, but also to our community partners, and helps people recognize not to be afraid, but to act. And then lastly, in terms of the tools, we really hope and focus on SMART goals. All of us need feedback. And so the key component of this intervention is to give feedback to the women about how they're progressing, whether the goals are working for them, and how to set goals that actually do work. And so many of you may be familiar with this acronym, but we are helping people establish very specific, meaning not outlandish, measurable goals that are achievable, realistic, and have a timeline, so that as we talk with these women each week, we can give them feedback as to how they're progressing towards their goal. So here's just an example from previous work that we've done, and we hope to share similar examples with you at the end of this project with the women. But this is an example of how SMART goals can help. And the first blood pressure on this patient's log, I'm not sure if you can see at the top, was 217 over 115. And this is not that uncommon for our geographic area and patient population. They're very high risk, true for the men as well as the women. And at the end of the month, the blood pressure had dropped dramatically. And in the follow-up conversation with this particular patient, the blood pressure was down to 110 over 66, well within an acceptable range. And the SMART goal was reported by this patient as the thing that really helped him to make the change. The patient reported, he asked, he did exactly as we discussed. I did what you all said about eating and have been walking every day. So activity and lifestyle change in this case was helpful. This is a second example about how engagement and ongoing engagement and communication with the study team, the Alpha Phi ambassadors, how that can really play a key role. In this case, the initial blood pressure was 169 over 114. And it didn't drop until later on down in the month when medication adjustments were needed. And the important point to be made here is that the follow-up, the engagement of the participants with our team was critical, and it helps them to, I think it helps in general, people to see the value of communicating more frequently with their healthcare provider. And this is step 4. And step 4 is really the nuts and bolts of our partnership intervention in this case. It is to help sustainability. And so we are really striving not only to conduct one-on-one coaching interventions with the women, but also to help the women choose a partner. And the partner is intended to be a partner from the community that is available to them, accessible in their everyday life, to help support accountability and help the women have somebody outside of themselves to recognize what their health goal is and help them get there. So some examples of our partners are represented here: the daycare and local beauty salons, in addition to community support programs that we have here in Durham. This initiative, improving the visibility of women through partnerships in the community, is expressed here as really our vision, which is to improve women's confidence in self-monitoring and medication management for hypertension, that can change the culture of blood pressure self-management to be seen not as a burdensome task, but as a liberating set of choices that they design to fit their own lifestyle. And now I look forward to sharing a short video from some of our participants.
I'm really passionate about addressing health disparities and preventative care, and I feel like this project is a really great way to directly interact with women and help them empower themselves and take control of their own health.
For me, it is important for me because I am big on being able to help other people. So if there's anything that I can do in any way possible to help other women, then I'm down for it.
I really do hope that this program can come up with something that would be helpful for us and beneficial for us.
With Alpha Phi, we do a lot of fundraising as our main philanthropy is related to women's heart health. So I was really excited to get the opportunity to work on this project and extend that philanthropy beyond just doing fundraising measures and actually to get involved with a more hands-on project.
It is important for me to be involved with this project because my whole life I've had a strong passion for service, and my academic interests revolve around analyzing genetic and environmental impacts on health. And I'm really grateful for the opportunity to extend my experiences beyond my curriculum and actually get the opportunity to interact with women in the local Durham community.
It seems as though even with changing my eating and being more active, it still is running high, and I'm trying to regulate it.
I know that hypertension for African American women, there's really high rates. So if there's anything that can be done other than having to take medication to regulate that or to bring those rates down, then I'm down for that just as well.
This is a great project because I think education is a large part of it in the African American community. I could go on for longer just to, when it comes to upbringing and eating habits and what's important and what's not important and how to cook. And it comes also down to cost. Just a lot of different factors. And I think it would be important if the African American community knew ways around that.
Health outcomes or potential outcomes that I wish to see, particularly involve health inequities, Black women, and the issue of hypertension. Mainly, I will hope that the women that participate in this project are able to feel empowered, and in that they feel in control of their health. They see a significant change or reduction in their blood pressures, using the tools and the knowledge that we hope to provide, in that they can move forward, feeling as the driver of their health, and they can move forward while centering their own health and well-being.
Thank you. I also just want to end this section of the program by sharing the real impact of student involvement. And you heard there from a few of the Alpha Phi students that we are excited to work with this coming year on this project. But here, just a short summary of the students that we've been able to involve over the last couple of years, the publications, presentations, and the opportunity for them to excel and to grow and to learn as a part of this hands-on project is something that we put a lot of time and emphasis on, and we value quite a lot. And here's a couple of examples of students in the news and some of the publications that we have done in partnership with students over the last couple of years. We look forward again to doing more of this kind of work with Alpha Phi. And here is a picture from last year's student cohort, and the diversity that we've been able to have, we feel so fortunate for that. And we really want to also share the fact that among all the students that we've had a chance to work with, I think we've all learned and grown from each other, and we've had a really good time. So without further ado, I want to say thanks and introduce to you our project coordinator for this coming year, Mnazo Muhirwa, who we are very fortunate and proud to have not only as a PhD student here at Duke University School of Nursing, but also working with us on this project. And Mnazo, I turn it over to you.
Thank you so much, Dr. Granger. I appreciate this opportunity to present to you all. Just to provide a brief introduction of who I am. I'm Mnazo Muhirwa. I'm fourth year PhD candidate in the School of Nursing at Duke. My research interests involving Black women sort of emerged from my experience as a registered nurse caring for Black women with cardiovascular disease. I noticed worse health outcomes among this population that were due to factors beyond just their diagnosis. For example, stress. That's how I've come to study the relationship between cardiovascular health and the relationship between stress and cardiovascular health in this population. I am interested in viewing and measuring stress among Black women, specifically through the lens of the Superwoman Schema conceptual framework. And this multidimensional framework captures the unique stress experienced by Black women. And this stress results from their identities as being Black, as a woman, and as medically underserved. And all of these identities intersect to perpetuate health disparities. And so my current work aligns well with the objectives of this project. As we all know, the goal of research is to bring about new possibilities for the future. And I know we all envision a future in which Black women are thriving in good health. Next slide. So one of the priorities of the Alpha Phi Foundation is advancing women's heart health through research. We have the privilege of having 3 amazing Alpha Phi student ambassadors as an integral part of our research team. Dana, Alex, and Haley share a common interest in understanding and addressing health disparities among the most vulnerable population. And we are so excited that they have decided to dedicate their time to this project. As you can see, they have a very extensive and impressive background. Next. And so to kick off the project, we began enrollment this month by contacting women in the highest risk group. During these calls, women have the opportunity to complete several activities. So one being establishing a relationship with the student ambassadors, as well as set up SMART goals related to health promoting behavior. And finally, identify and begin working with a community partner of their choice. So for example, in our enrollment, we've already had one particular participant who has selected their neighbor to accompany them on walks and hold them accountable for consistently checking their blood pressures. And so the student ambassador, as well as myself, will be in charge of following up in the progress that this particular patient makes. So next slide. So thank you again so much for the opportunity to present. We thank the foundation for partnering with Duke University as well as Lincoln. I open the floor up to any questions and discussions.
All right. Thank you, Brady, Holly, and Amnazo for your amazing presentation. I learned a ton even after having spoken with all of you multiple times about this project, and I'm really excited to see where it goes. So why don't we jump into our Q&A? I've received some questions from viewers of this presentation. So many people, just like myself, are very interested and excited to learn more. So why don't we kick it off with, how are you planning to continue encouraging participation in Lincoln Community Health Center patients and engage them to keep their relationships going throughout this project?
So the point of the community partner is to have that person will remain a part of our patients' lives, and Lincoln Community Health Center will remain a part of those patients' lives, but we're trying to sort of forge that relationship to help support her after we've done our 4 calls and our initial contacts.
Great. Brady or Amnazo, anything to add?
I'm sorry, can you repeat the question one more time?
Sure. How are you planning to encourage participation in Lincoln Community Health Center patients and engage them to keep their relationships going?
Oh, absolutely. I think that's one of the most key things in selecting a community partner. One is, it's not that we're selecting the partner for them. And so our hopes is that the patients select someone that they feel comfortable, because in the care of hypertension or high blood pressure, certain topics might come up, and we would hope that they, for example, we have the mother-daughter duo. Patients, what we're seeing is patients are selecting people that there's a deep connection with. And so in their engagement with us, they're providing the tools that we hand the tools, we educate, and then we release and hope that they can navigate it. They have all the tools needed to navigate and successfully implement these tools without the need for us to be present.
I think I'll add to Amnazo's response too, because that is the whole crux of what we hope is the innovation in this intervention compared to others that have been tried in the past, is the focus and emphasis on sustaining the accountability piece, in that it becomes an embedded part of the lifestyle. So I think that's exactly right. We're helping to encourage them to design their own activity schedule, their own partner, and their own regimen that works for them.
So in our work with men, we really enjoyed the in-person class. That was so much fun. But we found that it reached older people much more because they were retired, they had more time to focus on this, and there were a lot of younger people that we wished had come, but I don't think, it doesn't fit into your life to come in during a business day and get education about your health, nor did some of the patients feel at a younger age that they had any problem or that they needed any help. So the in-person classes weren't reaching what I think is probably the most prevention, heavy group. So we found after COVID hit and we had to do the telephonic outreach, that we were suddenly reaching people who were younger, busier, and maybe more likely to prevent their first heart attack or stroke.
Great. Thank you. Okay, so going off of that, we have a question kind of about relating to the video that we saw. So we saw Arlene and her daughter give their testimony about being part of this research. So since the participants are picking their own partner in accountability, are they similarly motivated to take measures to avoid hypertension as well? So are they sticking to the same plans, or are they just there to cheer the participant on?
it's really tailored towards the needs of the patient. And so one patient might, you see the mother and daughter duo. And so if you look at literature, you see that oftentimes Black women are these gatekeepers of their communities. And so implementing change within Black women kind of trickles down to all those that's incorporated in their community. And so you see the mother who might be in charge of the cooking, it will trickle down to the daughter, and then it will trickle down to the daughter. So it's very specific to what the patient might need. And so you will have another patient who just needs that accountability partner. So somebody to call them or follow up with them should they need that accountability partner. Did you check your blood pressure today? Did you go for that walk? Did you take your medication? So all about the innovative way that we can strategically tailor the specific need of each individual patient.
Great, thank you. All right, our next question, why is teaching to future nurses and doctors critical in the healthcare field, but especially in your project?
Well, I think Dr. Biola should kick this off. She's done such an amazing amount of behind the scenes work with the providers at Lincoln.
So why is it important? So one of my favorite attendings used to say that medical information is kind of like stocking bread at the grocery store. If you're putting all the fresh stuff up there, while you're putting the fresh stuff up, that some of what's up there has gone bad. You're just not sure what of the information you have stuffed away in your head might have expired and what's still good. So medical information is changing so fast all the time. It's really impossible in a primary care setting to keep up with everything all the time. The quality improvement team here at Lincoln has worked hard with our other providers here at Lincoln to make a hypertension treatment algorithm that's based on the most recent evidence. And we review it regularly with our providers here just to make sure that in terms of medication, we're following the most recent evidence because it's changing all the time. With diet and exercise, that bears repeating at every single visit, and we've got a little clicky box for it in our notes that we've done that just to keep reminding us. Our nursing staff helps with this as well, and our patient education team, and Nazo, our severe hypertension outreach project leader. So I don't know if I addressed that or not.
Yeah, Nazo or Brady, would you like to add on to that?
Well, I'll just point out from the video that one of the things that Arlene talked about was the importance of information, and that we know as researchers, we know information is not enough because we have a lot of information and it's not being applied and used. So I think the point here is to take the information and using the community partners, using our team to get that information in the hands of patients, but not just dump it there, to really give it as in the form of these activities that can be shaped to their everyday life, that they can sort of self-design, and taking the information and making it live and active in the course of a day is something that we're really striving to do. And I think that's different from just plain educating, and it helps to make the rules less burdensome and more of a guide.
Great. All right, we have time for a couple more questions. So we are really excited to see that there are Alpha Phi students working on this project with you all. Can you talk a little bit more about what these students will be doing in the project, and if there's other opportunities for Alpha Phi alumna who may not live in the Durham area to get involved?
I can answer the last part. I think the goal that we have is to be able to demonstrate that this is an effective approach and then scale that. And so the ability to demonstrate it is before us this year. And then we do hope that we can scale the success and the key nuggets that we've learned through working with women this year, and broaden that out to a larger group, a larger national group. And we're always excited to have student involvement, especially from Alpha Phi students who have been terrific so far. It's just, we can't say enough about how great it's been to work with this chapter.
Absolutely. And I'll just add, the students are almost taking the lead, and calling patients, engaging them in their own care by checking blood pressures, ensuring that they do have a blood pressure cuff at home, readily available to them. If not, coordinating how to get a cuff to the patients, whether to see myself through a nurse visit or Desi, to coordinate that exchange of blood pressure cuff, making sure the patient is educated on how to properly take and use the blood pressure cuff, as well as selecting the community partner of the patient's choice, and following up on those SMART goals and any other activities that the patient community partner engages in, to really make sure that we are seeing the progress being made.
Great. All right, and we're down to our last question that we have time for. To everyone else that asked questions in the chat, I will send these off to our team at Duke and get back to you with their answers, because we unfortunately did not have time for all of the questions today. So our last question, there's lots of topics related to women's heart health that could be researched. What drew your team to this project specifically, and within your area, focusing on, you know, the marginalized or disparate communities that you see every day?
I think Dr. Biola's slide in the very beginning set the stage for us in showing the very high risk that Black women in our community run, and also nationally. So both the national data and the local data are just emphasize the gap in care and the opportunity to close that gap. So we were really, I think, driven by the data and by our partnership with Lincoln Community Health Center. And I don't know, Holly, if you want to say more about that.
I guess there's a lot of things we know about hypertension, about high blood pressure, and how to control it. What doesn't seem to be as well known is, how do you actually get those things to happen? How can you get a busy mom trying to take care of her aging parents and her little children, who's working 2 jobs? How do you help her to get her pressure down? What's the next step in that situation? There's not a lot of boots on the ground efficacy data in that population. And so we're trying to figure out with our menu, what do people choose? What does work? What does it take to get better? So we're sort of playing on women's relationships and the strength of our need to care for others with this community partner. And we're happy to see that it's working, that people are like, oh yeah, I want to get better. Oh, but my daughter, if I could bring my daughter into this, I'd be so into that, because they want to help their daughter as much as they want to help themselves. So it becomes a community effort that we're hoping to really make some headway with.
Awesome. Well, thank you for answering so many of our questions that our viewers have had today. And it's been such a pleasure working with all of you since you were awarded this grant back in February of 2021, I think. It's been an honor to see some of this research, and I'm really excited to see where it goes. And with that, I will pass the mic off to Dr. Jennifer Freeman for our closing remarks.
Oh, excuse me. Hi, everybody. So like Alex said, I'm Dr. Jennifer Freeman. I was an Omega in Alpha Phi, and then I volunteer with the foundation, as well as am part of the Heart to Heart Advisory Council. On behalf of the Alpha Phi Foundation and our community, I will echo what Alex said, and we are so excited to virtually present you a check for $100,000 to the Duke University School of Medicine. We are so excited about being your partner and working together to identify and reduce all these disparities and inequalities that we see among women with high blood pressure. So to close our time together, again, just echo the thanks for your team at Duke, all of our foundation volunteers, staff, and donors that make this possible. As an Alpha Phi and a foundation volunteer, it always brings me joy to pass on my love of research. Funding is extremely hard to come by, especially now in our current environment. And I am so excited to say that not only are we encouraging women in scientific research, but we are also encouraging the research of women, both of which are essential, at least in my humble medical opinion. Over the last 28 years, the Heart to Heart Grant has funded projects that have had a tangible impact on the way millions of women encounter cardiac challenges in their daily lives. This grant has increased from $10,000 to $100,000 each year, and we have plans for even bigger things on the horizon. Alpha Phi is known for leaving a mark on history, and I am proud to say that as we approach our 150th anniversary, we're making history yet again. Through Leading with Heart campaign, more Alpha Phis than ever have benefited from leadership grants and received scholarships to help them advance and matriculate. Leading with Heart is also deepening our impact on women's heart health through an endowment that will benefit generations to come. Today's event was a wonderful way to celebrate and recognize ways in which we fulfill our mission for advancing women's lives by leading with heart. And thank you so much for joining us as we recognize our 2021 Heart to Heart Grant recipient. Enjoy the rest of your day, and thank you all for leading with heart.